I think it already kind of is in some states. I don't live in those states, but I do think it's being used in some states very widely for all kinds of different things. And the trouble in my mind is that there isn't a lot of evidence, and we don't know a lot of the long-term risks because it hasn't been studied. So you run the risk of kind of the same thing as the opioid problem. Like, this is great, use this for everything, and then all of a sudden 10 years later you have all this data that says maybe this isn't as great as we thought it was, and then you're reining it back in. So I do think it has a role. I do palliative care, and so patients will frequently ask about it or tell me they're using it or know someone who's used it, and I'm not going to tell them not to because of the patient population I work with. It's so limited what they do have that is efficacious. So I'm like, okay, if it works, try it, do it. But I do worry that there could be a potential for having to rein in something that's already been let out of the barn. But there's only one way to know, and that's probably going to be 10 years from now. My opinion is that is very limited scope. I don't think that all patients will benefit from that as a pharmacist. I know that there are pharmacogenetic variables. I know that there are pharmacokinetic variables. There's all kinds of things within an individual that make a dose unique to that person and don't make a dose a generalized blanket dose for the whole world. It just doesn't work that way. That's not how drugs work. I also worry about doing conversions, because I do a conversion from one opioid to another and someone else does it, and we don't necessarily always come up with the same dose. So 90 milligrams, 100 milligrams get there via one conversion method or another. It might not always be the same, and so I do worry who's doing the conversion, what method they're using, and that's not necessarily always going to be standard. I also have seen, unfortunately, in my practice, where the insurance companies are just adopting these numbers and these ideas without a whole lot of scientific background or a whole lot of really good options to replace something with. So they're giving you alternatives that they'll pay for that don't actually therapeutically match the thing you need to have covered for the patient. And these are patients also sometimes have palliative care needs, and that just to me seems completely unfair and wrong. And chronic pain should be no different. People should not be losing access to things that could be helping them just based on an arbitrary number.